Hello and welcome, everyone. I'm so pleased that you're all here to join us today for this month's webinar. We're going to be talking about prostate cancer and prostate cancer awareness because it is November. So really excited to go ahead and get started. So let me go ahead and share our screen here so that we can get right into this. So starting out here, we have November, of course, is Prostate Cancer Month. And it's really important that we talk about prostate cancer, what it is, how it relates to us, and also just kind of give the opportunity to highlight a health topic for the month so that we can hopefully be talking about this as we continue to move forward in the rest of the month. So let's go ahead and move forward here. So of course we have our typical disclaimer. Again, this presentation is intended for informational and educational purposes only. While I am a licensed physician, I am not acting in the capacity of a physician for this presentation, and the content provided herein should not be construed as medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical conditions. Never disregard professional medical advice or delay in seeking it because of something that you have heard or seen in this presentation. And of course, no doctor-patient relationship is being established through this presentation. All right. So let's talk a little bit about Wellspring Healthcare. So at Wellspring Healthcare, we certainly believe in the power of compassion, effective communication, and then empowering education to certainly transform lives. As a trusted provider of healthcare services, we're dedicated to delivering personalized service to you. And so we welcome the opportunity to be able to care for you and your loved ones in numerous rehab facilities and skilled and nursing home facilities in the Kansas City area. So certainly, let's always keep in touch. You can reach out to Wellspring Healthcare by touching base with William, our medical assistant. His telephone number is listed. And then also, if you're a leader at a facility and you're interested in partnering with us, we would be more than happy to try and have a conversation with us. And so you can reach out to us at wellspringhealthcare.org, or certainly you can reach out to our Chief Operating Officer, Brandy, at the number listed here at 816-708-1658. We look forward to talking with you soon. All right, well, let's jump into prostate cancer. So this is prostate cancer. You can see here that the purplish structure here is, and you can kind of see the arrow here. This is the bladder, and then this is the urethra. So this is where urine comes out, and then this is the prostate. And the prostate's function is to, it has a number of functions, but one of them is to produce seminal fluid, and it needs to go into the urethra at that point. And so a tumor, which you're seeing here, is a cancerous lesion, and it can sometimes cause a compression on the urethra, which makes it difficult for people to urinate. And we'll talk a little bit more about that, but that's just a good illustrative purpose of what exactly prostate cancer is. All right, let's move into this. So prostate cancer 101. So it is the most common type of cancer in men. It affects 29 per 100,000 men. So that doesn't sound terribly common, but it is quite common. It most often affects men that are older than 65. Now, the good news here is that prostate cancer is usually quite well tolerated. So it has a 99% survival at 5 years. And of course, early prostate cancer is mostly asymptomatic. So sometimes we will do significant screening tests in order to help identify if we're having prostate or early prostate cancer. Now, advanced disease, like I talked about just a moment ago, may have symptoms with difficulty with urination. They might find blood in the urine, erectile dysfunction, and or even bone pain if we're having very extensively advanced disease where our prostate cancer unfortunately has spread to bones, which is a very common place for the cancer to spread. So screening for prostate cancer, that's what this talk is primarily all about. Now, going back to last month's webinar where we talked about breast cancer during October, when to screen is certainly a subject of controversy. So there are a number of different organizations that are out there, and they will start recommending when we screen, how we screen. and who we screen. So the National Comprehensive Cancer Network, this is sometimes abbreviated NCCN, they recommend starting screening at 45 years of age. However, the American College of Physicians, which is what I'm a member of, and the American Urologic Association recommend screening between the ages of 50 and 69. Now, the United States Preventative Services Task Force recommends a very similar screening to the ACP, but they recommend starting at 55. So you can see here that there is a range of screening recommendations. So it's important to talk about this with your doctor to make a determination of when you should start screening. You'll notice that only the ACP and the AUA have a recommended cutoff of 69. Other organizations will recommend stopping screening at a certain age. Now, so how do we screen? So the PSA test is the most common test to screen for prostate cancer. So the good news for a lot of men out there is the PSA test is a very simple blood test that we can do. So the unfortunate process with this is there's not really a strong correlation between the level of the PSA and whether or not someone has cancer. So we can't detect and say, oh, well, anyone over this limit has prostate cancer. That's not the way that it works. Instead, it's a screening tool, meaning that there's not a high sensitivity to it, meaning that it doesn't clearly tell you whether or not someone is going to have the disease or not. And so the problem with this screening test as well too is that it changes with age. So if you're between the ages of 40 and 49, the upper limit of your PSA level should be 2.5. So if you had a PSA level that was, say, 7, well, that would be cause for concern, and we would want to do some further testing and further evaluation in that situation. Now, if your test was below 2.5, then we would be completely appropriate. Now, if you were instead, say, 65 years of age and your PSA level was 3.5, well, that would be normal for someone that's 65 years of age. And so we would not do further testing in that situation. So the PSA fluctuates, and we need to kind of have a baseline range of where to look at. And this is where it's important to, again, talk about this with your doctor. Now, the general consensus is that we would recommend screening every 2 years. So that's a good news as well, too. You don't have to have this test every single year, and that we can do it every 2 years. So what are some other tests? So let's say, for instance, your PSA level comes back slightly elevated. One of the things that we could do is we could do a digital rectal exam. So if we think back to that very first picture, that cancerous mass looked a little bit abnormal. It looked a little bit irregular in its shape. And so the prostate would change its overall texture. And so we can palpate the prostate. The prostate sits right up next to the wall of the rectum. And so it's a way to be able to do a rectal examination. And you can palpate the prostate. So certainly most men, not terribly desirous to have this test done. And the good news is that it's not recommended as a standalone test. So we would not just do a digital rectal exam for the sake of doing a digital rectal exam. We would instead do that in conjunction with the PSA test, and especially if the PSA test was slightly elevated. So now we've done a PSA test and it's elevated. So if we go back to our chart here, let's say, for instance, we're someone that's 65 years of age and our PSA test comes back above the upper limit of normal, even for someone that's, say, 70 to 79. And so the PSA level is now 8 or 6.5. So we would then in that situation do a digital rectal exam and see if we feel any difference in echo texture. And if we do feel this is when we're going to refer out away from someone like myself, which is a primary care provider, but refer you to a urologist at this point, because at that point, we're going to need to do more invasive testing. And that's when you're going to go and speak with the urologist and talk about a prostate biopsy. And so this is where we get into these different various testing levels of whether or not we're 3 nanograms per milliliter and we have a suspicious digital rectal exam. Now, this number varies based upon the age. Don't forget that. And of course, in our example, if we have someone that's 75 and they have a PSA level of greater than 4. So again, we have to have an individualized approach to prostate cancer screening, very similarly to like we did with breast cancer. But screening tests are very important to be individualized for each person. And so it should be based on a number of different factors, but it should be based upon our life expectancy and our probability of whether or not we're going to have clinically significant cancer. So if we are a young person that is relatively healthy and a long expected life expectancy, that's going to be someone that I think it's important to make sure that we're doing some screening on. Now, if we become 85 or even 75 or even 65, but we're very frail and we have a long standing history of underlying medical conditions, or we're already enrolled in hospice, or we have elected that we don't want further cancer testing or invasive testing or things of that nature, then screening may not be appropriate for that person. And so that's why, again, it's very individualized. We have to take your risk tolerance and weigh that against your comfort levels. So those are, again, conversations that you need to have on a one-on-one basis with your provider. So let's say, for instance, we've done some screening now. Unfortunately, we have identified an elevated PSA level, and so we need to do some further evaluations. And so the urologist has come back and told us that we do, in fact, have prostate cancer. Now, that prostate cancer we would then stage so that we would get an idea of, is it local cancer or is it advanced cancer? And so if it is local, our treatment strategies are going to be a little bit different. If we're of highly advanced age, we may elect to proceed down a pathway of something simple like observation. But if we're younger and the cancer unfortunately has spread, we may do something more aggressive like external beam radiation or brachytherapy. This is where we can actually implant these radioactive particles into the prostate itself so that we can kill the cancer in a local state. Sometimes surgery is important, and that's what this radical prostatectomy is. Or because the prostate is a male organ only, it is testosterone sensitive a lot of the time. And so we can do androgen deprivation therapy where we block a male's testosterone hormones and their androgen hormones, and that can starve the cancer, because a lot of times the cancer is dependent upon those hormonal therapies in order to continue to grow. So in summary, prostate cancer is common. Screening helps us to detect prostate cancer early, and we want to start and stop screening as an open discussion with your physician. So you can start screening earlier, and especially if you have a family member that got diagnosed with prostate cancer at an earlier age, that would be an indication to go ahead and start sooner. And again, have those conversations with your primary care provider, because we want to make sure that we are healthy moving forward for future generations. So again, please don't hesitate to keep in touch with us. Reach out to our medical assistant, William, or Brandy, or of course, follow us on our website at www.wellspringhealthcare.org. So again, I'm very excited that you took the time to come in and meet with us today and to watch this webinar, whether you're catching it in real time or whether you're catching it after the fact. We're very pleased that you took the opportunity to come and be here with us. Just checking the chat real quick to see if we have any questions in our chat. Does not look like we have any questions at this time, so that's wonderful. Hopefully that means that I explained things well for you. Now, I want to make sure that I offer up the invitation to you now. We are going to have another webinar happening in 2 weeks on November 15th at 6 p.m. And this one is going to be a joint webinar. I'm really excited about this, with Ascend Hospice. And we're going to talk about the introduction to end-of-life care. We're going to define end-of-life care. We're going to talk about the importance of end-of-life care. We're going to talk about the differences between what we look at as quote unquote regular care or standard care, and also in fact end-of-life care, and see what those differences look like. And that'll be a special webinar, and we're going to do a series of 12 of these once per month where we talk about different hospice categories as well. So I look forward to seeing you all there, and hopefully have a wonderful, healthy